Thank you. Good afternoon, everyone. I'm Lisa Waugh with the NCSL Health Program, and on behalf of the National Conference of State Legislatures, I'd like to welcome you all here today. Today's webinar is Healthcare Waivers 101, the first of a two-part series for states on healthcare waivers. I'd like to remind participants that NCSL is a bipartisan membership organization of state legislatures. NCSL advocates for the interests of states and provides policymakers the opportunity to exchange ideas. This webinar is a platform for information exchange. We encourage a robust Q&A, and at the conclusion of the presentation, and we'll remind participants that they can ask questions at any time during the webinar. You can ask a question by writing into the box located on the lower left-hand side of the screen. Before I introduce today's speakers, I wanted to thank the Health Resources and Services Administration for their support of today's webinar. Here at NCSL, we receive a number of requests from states asking for information and clarification about opportunities related to federal health care waivers. So with us today is Representative Jim Dunnigan, who is the co-chair of NCSL's Health and Human Services Committee and Majority Leader in the Utah House of Representatives. Representative Dunnigan will introduce our speaker for today, who is Cindy Mann.
Thank you, Lisa, and good afternoon, everyone. I would like to thank NCSL for arranging this opportunity for state policymakers to learn more about the opportunities for states with Medicaid waivers and federal health care waivers. We are all very aware of the potential for innovation through waiver opportunities, and as a legislator, I'm also too aware that controlling healthcare spending still remains one of the biggest challenges for states. This webinar provides us with an opportunity to hear from one of the national figures who has key expertise in this area, given her many years of experience with the Centers for Medicaid Services, or CMS. She is going to focus on Medicaid 1115 and 1915, as well as HHS Section 1332 waivers. Utah, my state, has 8 Medicaid 1915C HCBS waivers, and they provide home and community-based services to a limited, targeted group of individuals. For example, people with brain injuries, people with physical disabilities, or people that are over age 65. Utah also has a unique pending application for Medicaid expansion through an 1115 demonstration waiver. Utah's primary care network is a statewide Section 1115 demonstration to expand Medicaid coverage to certain able-bodied adults who are not previously eligible for state plan services, and to offer these adults and children, if they're eligible for CHIP, an alternative to traditional direct coverage public options. In early June, I met with Vicki Wachino of CMS in Washington and talked to her about this unique waiver that Utah was preparing. We submitted our new 1115 waiver on July 1st of this year, and we are just starting to work through the process of waiver consideration through with CMS. I think I can speak for a large number of state policymakers when I emphasize how important it is for us to fully understand the potential for waiver opportunities, including the proposed 1332 federal waivers. And for this reason, I'm very pleased to be here today to introduce Cindy Mann as our speaker for this webinar. Cindy Mann is a partner at Mannatt, Phelps and Phillips, where she works with clients to develop and implement strategies through federal and state health reform, Medicaid, the Children's Health Insurance Program, and delivery and payment system transformation. Her clients include states, providers, plans, consumer organizations, and foundations. As I mentioned earlier, before joining Mannatt, Cindy was with the Centers for Medicare and Medicaid Services. There, she served as the Deputy Administrator and Director for the Center for Medicaid and CHIP Services. She led the administration of Medicaid, CHIP, and the Basic Health Program for more than 5 years during the implementation of the Affordable Care Act. She set federal policy, supported state program operations, and coordinated policy and program operations with the marketplace. During her time at CMS, we at NCSL benefited from her participation in many of our meetings and discussions. It's my pleasure to turn the time over to you, Cindy.
Thank you so much, Representative Dunnigan. And it is a pleasure to be here today with you and with the leadership at NCSL. And as indicated by my presence at many NCSL events and meetings while I was at CMS, I so value the opportunity to have occasion to talk to legislators and their staff and to make sure that some of the complexities of healthcare law and Medicaid in particular are not seen as barriers for states to be moving forward and to design the kinds of Medicaid and healthcare programs that they think best meet the needs of their state and the residents of their state. So as the representative said, there's always a lot of questions about what can be done through waivers. And what we're going to do today is to talk I'm sorry, I'm trying to figure out the cursor. There you go. To talk about healthcare waivers and when you need them, when you don't need them, and we're going to focus on three main sources of waiver authority. And there is a follow-up session also, as noted in this slide, on August 4th, where we're going to specifically dig into 1332 waiver. And the notion on that is that it's a new waiver in town, less experience on it, somewhat complex, so we're going to touch upon it today and explain some of the basic rules on it, but then dig into that issue. And there may be some other questions that come up through this webinar for which we might not have as much time as the audience demands to cover those topics. So let me start really by talking about what you may not need a waiver for. I know this is a Waiver 101 discussion, but it always makes sense to me to start with when would you want to turn to waiver in the Medicaid program? And often it is seen as an opportunity to be innovative, to do something really different. And that is certainly true, and waivers can give states those opportunities. But they come with a fair amount of negotiations with the federal government and protocol and rules of the road. And I think it's important at all times to understand that there's some underlying flexibility and considerable underlying flexibility in the Medicaid program. And some things that a state may want to be doing or think that their Medicaid agency ought to be doing actually can be done quite simply, at least in terms of legal authority. Maybe the task is not as simple without needing a waiver. So this slide gives you a sense of just some examples of the flexibility in the statute, in the Medicaid program, that states have and can exercise without going to the federal government to request a waiver. One area is around coverage design. Who is eligible for the program? Probably the most clear-cut example of where a state can make a change in terms of coverage design is who's eligible, and the decision about whether to expand or not expand under the Affordable Care Act's adult expansion provision can be done without a waiver. Most of the 31 states have taken the expansion up at this point, and most of them have not used a waiver, but a good number of them have, and we're going to discuss those waivers later on in the webinar. But if a waiver isn't necessary to move forward with the adult expansion. You also can streamline your enrollment procedures without a waiver. You can have a fair amount of flexibility, particularly for adults, around your benefit package without using a waiver. And cost sharing is an area that states have increasingly expressed interest in, and much of what you can do in cost sharing actually you can do without a waiver. For families and individuals with income below poverty, it must be nominal, but you can do copays. And the nominal is about $4 for most copays, $8 for some other kinds of copays. And for individuals, if you're covering them with income over 100% of poverty, then you can do cost sharing without a waiver that's equal to 10% of the cost of the service. So that's often not well understood by states because they often haven't covered individuals in that income range before in the Medicaid program. You can also do premium assistance, use your Medicaid dollars to be able to subsidize private employer-sponsored insurance. And so those are some of the coverage design options available to states where you can move forward, shape your program in different ways, and do so without going to the federal government for special waiver authority. In the area of long-term care, a lot of activity going on in this area, particularly states being interested in improving and extending the extent to which home and community-based services are available. It used to be you could only do home and community-based services for long-term people needing long-term services and support through a waiver, but that option is now opened up, and you can do it through a state plan amendment, meaning without a waiver. I think one of the biggest areas of flexibility for states is around delivery system and payment reform and what states can do without a waiver. Whether it's you're a fee-for-service state or you're a managed care state, whether you're looking to do accountable care organizations or bundled payments, you can do those activities. You can take on those initiatives without seeking a waiver. Some states have done it with waivers, and we'll talk about why you might do a waiver route, but those are basic areas of design that have been left to states in the Medicaid program and for which they don't need waivers to initiate. Similarly, payment rates, whether you do incentives in your managed care plans for certain quality or access initiatives, whether you are starting to share savings in your managed care with your managed care plans or have your managed care plans do shared savings arrangements with providers. Those are all kinds of activities that you can do in the Medicaid program without a waiver. And another example of delivery system and payment reform is to do health homes, which is to do care management, intense care management for people with multiple chronic illnesses or people at risk with chronic illnesses. You can do that without a waiver and actually can get a 90% match, the care coordination component of health homes. So it is the question becomes, how do you figure out, do I need a waiver, do I not need a waiver? Often states would come to me when I was at CMS, and sometimes they'd have an expensive consultant at the end and say, well, I'm here with a waiver, and you'd talk to them and say, well, what do you want to accomplish? Because actually you can do some of that without a waiver. So my suggestion always is to start with, what do you want to accomplish? What are the goals that you want to accomplish for your state? What program changes are needed to accomplish that goal? And then you can sit and with somebody at CMS or consultants or your Medicaid agency and say, okay, now that I have an idea of the kinds of things I want to accomplish, what kind of a federal authority will allow me to do that? Can I do that without a waiver? Do I need a waiver? What are the advantages of going for a waiver or not going for a waiver? So starting first with the goals and what program changes you want to accomplish usually gets you more to where you want to go than starting with, I want to do a waiver. So here's the kind of analysis that you might want to go through when you're thinking about how to shape your program or change some aspect of the program. An example here is a state saying, you know, I'm hearing that it's hard to get for people to get access to a provider in my state. I want to improve access. Maybe it's primary care, maybe it's specialty care, maybe it's in rural areas of the state. And so what you're looking at to remedy that problem is you might want to be looking at adequacy of your rates. Are your rates enough that it is attracting your provider community that you're targeting? Maybe it's enrollment burdens for your providers. We've heard from some providers that some state Medicaid program rules make it difficult to, or just a lot of paperwork to get into the program. Maybe you're a managed care state and there's a concern that your managed care plans aren't necessarily building a network that's adequate. All of those kinds of changes to improve access to care you don't need a waiver to accomplish. You can accomplish through a variety of initiatives, whether it's raising rates or whether it's easing the enrollment burden or requiring through contracting with your managed care provider a strengthening of network adequacy or incentives to certain providers to build up access. Those are the kinds of things that you don't need a waiver to do. Let me go to the bottom one, which is increasing consumer responsibility for costs. As I said before, lots of states have been interested as they've started to expand coverage up the income scale to think about whether there should be some consumer responsibility for some of the costs. So you might want to think about as a state legislator, I'd be interested in imposing some premiums on my Medicaid beneficiaries or doing cost sharing. So as I noted before, you don't really need a waiver to do copays, but you do need a waiver in the Medicaid program if you're thinking of charging premiums. The Medicaid program rules don't allow premiums for populations under 150% of poverty, and if you're interested in charging premiums for people at that income level and below, you would need a waiver to impose a premium. So in that circumstance, copays, maybe not, but premiums, maybe yes, you would need a waiver. So really thinking about what you want to accomplish, what the particular initiative might be, and then thinking about what authority you might need to accomplish that goal. So with that introduction to the analysis that you might want to go through before you jump into waivers, so let's talk about three primary types of healthcare waivers. And I'm saying healthcare waivers as opposed to Medicaid waivers because when I talk about the second one on this list, 1332, it's not really a Medicaid waiver. It is a waiver about healthcare, but actually not on the Medicaid program. So we're going to start by talking about Section 1115 waivers, and which are really probably the way when people talk about doing a waiver. Representative Dunnigan talked about Utah has submitted a waiver to the Centers for Medicaid and Medicare Services. That's a Section 1115 waiver. It is the waiver that is the more comprehensive authority for the Secretary to waive certain provisions, basically, of the law and allow states to do something that without the waiver they really couldn't do under the law. Technically, the law calls it demonstrations. There's supposed to be demonstration initiatives demonstrating a certain hypothesis and then evaluating that hypothesis, but they're commonly referred to as waivers because in some respects the Secretary is waiving, making go away a certain provision of the federal law. They're subject to evaluation. They're supposed to be testing our hypothesis, and generally they're approved for 3 to 5 years and subject to renewal at the state's discretion and with approval from CMS. They're also subject to public transparency requirements. That there's been different transparency requirements attached to waivers over the years. The Affordable Care Act increased those transparency requirements, requiring that there to be some public hearings, opportunity for the public at the state level to comment when a state is thinking about doing a waiver, and then opportunities at the federal level also for the public to comment. Not to have there's no public hearing requirement at the federal level, but there's an opportunity for the public to submit written comments. And in part, that transparency requirement is important at the state and the federal level because sometimes the waiver can make very fundamental changes in how the Medicaid program operates, and you're going to have interested stakeholders, and so Congress determined that there ought to be an opportunity for those stakeholders to weigh in. I'm going to focus on the two provisions that are at the bottom of this slide, which is what are the constraints around waiver authority? And the two important ones are that the Secretary of Health and Human Services must find that the waiver will promote the objectives of the program. And there's also a requirement that the waiver be budget neutral to the federal government, not cost the federal government more than what the program would have cost without the waiver. Before I get into the promote the objectives of the program, I should say there are certain parts of the federal law that the Secretary simply can't waive, that the Congress has put off the radar in terms of her ability to make go away. One of the most probably obvious ones that you would have guessed is the issue of the match rate. As probably most of you know listening into this call, Medicaid is a shared federal-state program, shared in terms of financing, mostly administered by the states, but obviously with some administrative authority at the federal government. And the amount of federal investment in your state Medicaid program is determined by the applicable match rate. Different states have different match rates set by the statute, largely driven by the state's per capita income relative to other states. Higher match rates for certain kinds of services in certain populations. For example, the expansion population has 100% match rate for the first 3 calendar years since the enactment of the Affordable Care Act. The Secretary does not have the authority to waive the match rate. So you can't say, I've got a great idea, why don't I get 100% match from the federal government for all my Medicaid expenditures? That would be a very attractive opportunity for states. Congress did not give the Secretary that authority. But it is still very broad authority. So let's look at the constraint of that authority. It really is that the Secretary determined that the waiver proposal promotes the objectives of the Medicaid program. And here are the kinds of things that CMS has approved 1115 waivers for. States testing changes related to delivery system reform, relating to premiums. As I mentioned, you need a waiver to do a premium. We have now a number of states that have adopted premiums. And the Secretary has found that it's not inconsistent with the objectives of a health insurance program to have a premium. Certainly most of us who have health insurance in the private sector have paid premiums. But what the Secretary has determined as she's approved premiums in the Medicaid program is that because of the unique low incomes of the Medicaid population, that there will be guardrails on the amount of premiums that can be charged and the consequences for non-payment. So, for example, in Iowa, the first state that got a premium waiver in the context of a Medicaid expansion, there's no, people can't lose their coverage if their income is below 100% of poverty if they don't pay their premiums. They might have a debt to the state, they owe the premium, but they can't lose coverage because they're a very low-income population. On the other hand, CMS has determined, or the Secretary has determined, that states can terminate coverage under a waiver for non-payment of premium for people with incomes above 100% of poverty, but they've limited the amount of the premium to 2% of income, similar to what's charged at that income level on the exchange. So it gives you a sense that of how the promoting the objectives of Medicaid works. A determination overall is that an area, a kind of initiative that is consistent with the health insurance program for low-income people, and to the extent that that kind of initiative is consistent, are there guardrails that need to be applied to make sure that it is implemented in a way that's consistent with the objectives of the program. I want to particularly call out connecting to work because I know there's been some interest in that in some states to have a work requirement. The Secretary has determined that a work requirement conditioning health insurance coverage on being in a job or pursuing job search or job training is not my defined objective of a number of different federal programs and state programs, but it's not furthering the objectives of a health insurance program. That being said, some states have adopted initiatives that would help refer people who might be underemployed or unemployed to job referral centers, work training centers. So there can be referrals and opportunities to provide services to people, but not conditioning health insurance on work initiatives. So I mentioned also with 1115 waivers, it must be found to be budget neutral to the federal government. And this is not in the statute, it's actually not even in regulations, but it's a very long-standing principle that the Office of Management and Budget, which partners with CMS as they review waivers, requires that the state make it showing to the federal government that this initiative won't cost me more than the federal government would have spent without the initiative. And so every state that's making a waiver goes through discussions with the federal government about, well, they could have covered this population anyway, so covering this population isn't really an added cost to the federal government, so it shouldn't run afoul of budget neutrality rules. Or, for example, in the case of a premium, it likely lowers cost of the program as opposed to increased cost of the program. And so it doesn't run afoul of budget neutrality. Or if you're doing payment reform or delivery system reform, there might be some upfront investments and added costs, but overall the goal is, as a state might design it, would be to be more efficient, to be moving towards value-based purchasing strategies that overall will help curb the rate of growth. So budgets, there's a big part of discussion that goes on, again, depending upon the type of the waiver, around budget neutrality, and then there's mechanisms that are inserted in the agreement that's reached between the state and the federal government to ensure budget neutrality. It doesn't have to be budget neutral each year. So you can have a waiver, and states do have waivers where there might be actually explicitly added federal expenditures in the first couple of years. It has to be budget neutral to the federal government over the full term of the waiver, which is, as I said before, is usually 5 years, sometimes 3 years. Important to mention in waivers that they are like any other part of the Medicaid program for which you're receiving federal matching payments. It is not a grant program. It is another way to authorize spending through the Medicaid program. And so, as is true throughout the Medicaid program, states need to think about how they're coming up with their non-federal share of whatever the waiver expenditure is, whether it's an expansion of eligibility or a delivery system reform initiative. And like other parts of the Medicaid program, states have lots of flexibility, or a certain degree of flexibility anyway, as to how they're going to finance the non-federal share of waiver-related expenditure. They can use general funds, of course. They can use intergovernmental transfers. That's payments that are made by local governments, public hospitals. They can use provider assessment, provider taxes, and they also have used in some waivers something that CMS calls designated state health programs, where the federal government might invest in a certain initiative that the state or local government has, and that would in turn free up some state or local dollars that could be used for the non-federal share of the waiver initiative. So I'm just going to show you a map with a couple of states that have, with a couple of different initiatives of 1115 waivers. So this is a map of states that have moved forward to expand coverage to low-income adults under the Affordable Care Act. And the states in green are the 31 states that have done so. And the states that have the dark borders are states that have accomplished their expansion through 1115 waiver. Other states have done it without waiver initiative. It doesn't mean that they haven't done something different and innovative in their program. Oregon's a good example. Oregon has a waiver that is about delivery system reform. But when they did the expansion in Oregon, they did the expansion in a way that didn't require the authorization of a waiver, but they have already a delivery system reform waiver that has created community care organizations to change the way that care is actually delivered. By contrast, Arkansas started out its expansion with a waiver, and it's a state that decided to use its Medicaid dollars to enroll people in qualified health plans in the marketplace and to mandatorily require people who are in the expansion group who aren't medically frail to get their coverage through those QHPs, those commercial plans doing business in the marketplace operating in Arkansas. So it took on the expansion, but it did so through a waiver. I see here, I think there's actually a mistake in this slide. I apologize for it. Louisiana is listed here as a waiver state. They are the most recent state to expand coverage, but they actually didn't do so through a waiver, so that's an issue. One thing I want to point out is some states that originally didn't proceed with a waiver when they expanded coverage have now gone back to the drawing board. Sometimes it's through having broader experience. Sometimes it's because they may have new state leadership. So we have noted here that Ohio and Kentucky and Arizona are three states that proceeded to expand coverage under the Affordable Care Act without a waiver, all of whom have now decided they would like to have the certain waiver authorities attached to their expansion, and they have waivers pending or in various stages of development. For Kentucky, it's still at the state level in terms of public input, and for Ohio and Arizona, their waivers are pending at the federal government. So you could decide to expand without a waiver and then eventually put in a waiver, or you could be like Pennsylvania, which was a state that did decide to expand with a waiver. New governor came in and decided he didn't want the waiver, and he dropped the waiver. So they're a state that looks like a state that doesn't have a waiver, although they originally started with one when they did their expansion. So you're not locked into one path depending upon how you started. This other map shows you a little bit about states that have done what's called delivery system reform incentive payment waivers, district waivers. And these are states that have decided to use 1115 authority to do more significant changes in their delivery system or payment methods in the Medicaid program. As I said early on in the presentation, states can do a lot of that now without a waiver, but district waivers actually have been a way for states to bring down some additional federal dollars to help smooth the path as they've been moving to delivery system reforms. And we've got a couple of states, Virginia and Washington, with pending district waivers pending before CMS. Let me turn to the next group of waivers, and I'm going to go through this a little bit more quickly because we'll spend a little bit more time on this in the next webinar. But let me introduce you to Section 1332 waivers, which aren't even in effect yet. But I know there's a lot of questions and interest in these 1332 waivers. They were established by the Affordable Care Act, and they go into effect in January 2017. So that's the first time that a state can actually be implementing a 1332 waiver. What can be waived under 1332? Well, let me start with the fact that it is not a Medicaid waiver. So you don't use 1332 because you want to do a premium in the Medicaid program, or because you want to do delivery system reform in the Medicaid program, or because you want to do home and community-based services in the Medicaid program. You use 1332 when you want to change some of the other rules in the Affordable Care Act. Rules around the individual mandate, the requirement that individuals maintain health insurance coverage. You can use a 1332 waiver if you want to change the employer mandate, the rules that require large employers to provide coverage to their full-time workers. You can use 1332 waivers if you want to change some of the benefits in the marketplace available through the qualified health health plans, doing business in the marketplace, or if you would want to change the subsidy. Some states have thought that the subsidy level should be deepened, or that they might be smoothed out to have less cliff. You could use the 1332 waiver to do that. And in fact, you could use the 1332 waiver, and that's numbered B below, to eliminate the exchange altogether and to say, I'm going to make commercial health insurance, individual market, small group market health insurance available in a very different way in my state. I want to do it in a very different way. I don't want to do it through the exchange rules, and you could potentially use a 1332 waiver to do that. So while it's not a Medicaid rule, it is really applicable to the individual small group market rules. I do want to say that Congress anticipated that if the state really wanted to do a 1332 waiver around ACA-type benefits, subsidies, and coverage, they might also want to have that be accompanied by a Medicaid waiver. And so you can certainly do both, and you can do both side by side if your goal would attach to both the individual and small group market and the Medicaid program. So that all sounds like quite a broad opportunity to do waivers. So let me then turn to the guardrails. So the statute says you can do these 1332 waivers, but at the end of the day, whatever changes you make, the people can't lose coverage. That under a 1332, the coverage has to be provided to at least as many people as the ACA would have provided coverage to without the waiver. Similarly, you can change benefits. You can use your 1332 in that area, but the coverage must be at least as comprehensive as the coverage that would have been offered through the exchange without the waiver. Similarly, on affordability, you can make changes in affordability, changes in the premium tax credit, changes in the cost-sharing subsidies, but they can't increase out-of-pocket costs relative to what would have been available on the exchange. And overall, similar to 1115 waivers, you can't increase the federal deficit. And there's also noted at the bottom of this slide, certain things are off limits. You can't waive, a state can't use 1332 to waive the non-discrimination provisions. So what are the kinds of things that you can do under a 1332 and perhaps a 1332 plus an 1115 waiver? You could potentially smooth out the cost continuum. I've certainly heard from states and policymakers that they want to see an elimination or a smoothing of any cliff that happens when you have Medicaid and maybe the CHIP program and maybe the marketplace, that they're, a couple of dollars more in income. You might have a not insignificant change in out-of-pocket costs for consumers. They might want to smooth that cost continuum, and you might want to do that through a combination of 1332 and 1115 waivers. You could certainly create a Medicaid premium assistance program, buying a premium subsidy program through a 1332 waiver. You could also more fully align some of the rules, the eligibility and enrollment rules, across the spectrum of your health insurance program. So there's lots of different ways to think about it, but the guardrails are not insignificant, and they need to be paid attention to. And there's also some guidance that CMS issued last December that further amplifies some rules on how those guardrails will be calculated and figured out. Right now, we just have 3 states with pending 1332 waivers. As I said, they don't go into the authority doesn't go into effect until 2017. So these are the states at the head of the pack that are thinking about, beyond thinking about 1332 waivers, that have actually submitted applications. In all instances, Hawaii, Massachusetts, and Vermont, they're pretty narrow waivers. They are not waivers that would throw out the exchange and do very significant changes to the marketplace. They are really narrow changes to the individual or small group market. And in all cases, they are trying to get to some of the innovation that those states had before the ACA that they would like to restore in their programs. But these states are all also thinking about some additional opportunities to use 1332, and we've got a number of other states that are debating in their legislatures are considering opportunities under 1332. So it's not a small undertaking. I think a lot of states are trying to get themselves just settled from all the changes in the ACA, but I think we will see some additional activity under 1332 in the next period of time. Finally, I want to turn to the third area of waivers and just be brief and tell you about Section 1915 waivers. and Representative Dunnigan talked about the 1915 waivers that they have in Utah. So these are, the 1115 waivers are broad waiver authorities in the Medicaid program. 1332 waivers are broad waiver authorities outside of the Medicaid program relating to the individual small group markets. And the 1915 waivers are very targeted waivers that are applicable only to the Medicaid program itself. And there's three kinds of Section 1915 waivers under two different authorities. Section 1915B allows states to do mandatory managed care. And they also, Section 1915B allows you as a state to do what's called selective contracting. So you can just decide, for example, if I'm going to do Medicaid transportation in my Medicaid program, I don't want to open it up to everybody. I just want to have a selected number of vendors or maybe even one vendor who will provide that service. So you can do that under Section 1915B. It's a much more circumscribed authority for the federal government, but it's also an easier process to get through. And Section 1915C, almost all states, if not all states, have Section 1915C waivers. This allows states to provide long-term care services and supports through home and community-based settings rather than facilities. I mentioned this early on in the presentation, that you can do home and community-based services through a state plan. You don't need a waiver, but that's a new development, and a lot of states in those states are used to doing those kinds of services through 1915C waivers. So that's, I think, where I'm going to stop now, and maybe turn it back to you, Lisa, to help us go through some questions.
Yes, and thank you so much, Cindy. One of the questions that's come up on the screen is, can a waiver expand Medicaid to a specific population group, e.g. pregnant women?
You need a waiver to expand eligibility to pregnant women? Is that the question?
The question is, I think, how can a waiver expand Medicaid but only to a specific population group, not based on income eligibility, but based on sort of like the status of the applicant, like a pregnant woman?
Well, many states have expanded coverage to pregnant women, for example, at much higher income levels than they cover other populations. Often they'll cover pregnant women at least to 185% of poverty, some states much higher income range. That's also true for infants. Some states will cover very young children at higher income levels, and they've been able to do that through without a waiver. They can do that without a waiver, and if you go on Medicaid.gov, if you look at information about particular states, you can see state eligibility levels in that on that website, and you'll see the really significant variation across states in terms of coverage of pregnant women.
Okay, great. And another question that's come up is, what are some states that have received approval for work requirements in their waivers?
States don't have approval for work requirements in waivers because the Secretary has determined that a work requirement does not further the objectives of a health insurance program. You can have work requirement in your TANF program, of course. You can have, under certain circumstances, some work requirements in the SNAP program. But the health insurance is has a different set of objectives, and the Secretary has not approved work requirements. But there are some states that have used the enrollment into Medicaid as a way to reach people to refer them to work and training. And Pennsylvania was a state that was very interested in doing that. Indiana is a state that has been doing that. It has a waiver to do its Medicaid expansion, but it actually didn't need the waiver to do the work referral, but it is part of its expansion program to connect people to services that can help improve their employability or potentially help them get a job with that pays better with more hours.
Okay. What occurs if a waiver ends up not being cost neutral and instead creates additional costs for the federal government?
It is the terms of the waiver that's agreed to between the state and the federal government will set out the budget neutrality rules and will have checkpoints along the path of the waiver. Let's say it's a 5-year waiver. They'll be reporting to the federal government at the end, usually of each year, to see how the state is proceeding on with respect to budget neutrality, since the goal of the state and the federal government is shared, that nobody ever gets into this position where they're above budget neutrality. But if they are, they would have to pay back the amount of the spending under the waiver that exceeded the agreement that was reached. And I believe that's only happened once, at least in my knowledge.
Uh-huh. And I think this is related, I think you've already gotten to it, but is it safe to say that all waivers must remain budget neutral for the federal government, or are there specific waivers that don't have that requirement?
The 1915 waivers are not about budget neutrality, so they don't have that requirement to reach, again, because they're more narrowly targeted waivers. But it's 1115 waivers that have the budget neutrality requirement.
Okay. So another question is, if our state wants to add an optional service, like covering more diabetes or autism treatments, does that need a waiver, a state plan amendment, or just a new approved preferred drug list? Would you like me to repeat that?
No, I think I got it. So the benefit package requirements for adults give states a fair amount of flexibility. There's a certain group of benefits that must be covered, and then beyond that, the benefit package are optional with the state. And that's also true with the expanding population. You have to have at least the 10 essential healthcare benefits be provided, like physician services, hospital services, prescription drug services. But then there's a lot of flexibility within the definition of those benefits, and there's flexibility to add services. So if it's a service that the Medicaid program could cover, by and large, you don't need a waiver to add to it. If you're, and most, I think, commonly thought of healthcare services would be coverable under the Medicaid program. Autism treatment is a service largely, but not solely, for kids. And the kid benefit package is actually, the requirements are more robust in the Medicaid program. And so, in general, if it's a medically necessary service that the Medicaid program could cover, and it's needed for that child, it should be covered even without a change. So there's not really a sense of optional services for children, but for adults, there's a lot of services that are optional, and you don't need a waiver to do them. If you're trying to provide a service that isn't really a medical service, that's just something very different, you may need a waiver, like your 1915C waivers can give you the ability to do retrofitting of a residence. Let's say to make sure somebody's parent who's disabled can stay in the community and stay in their home, doesn't need to go into a nursing home. They otherwise don't need nursing home care. 1915C can give the state the authority to help that individual, help that family, perhaps build a ramp to allow wheelchair accessibility to the home. That's not a typical medical service, of course, and so waiver authority may be needed for some of those kinds of services.
Okay, there's a question here about how states are managing dual eligibles through waivers. Do you have any comments on that?
Sure. So dual eligibles are individuals who are both eligible for the Medicaid program and for the Medicare program. They can be the elderly, or they can be people with disabilities. And, a problem that has faced states through the ages is that often when they invest in care improvement measures for the dual eligibles, some of the savings begins, which might accrue, would be realized by the Medicare program. For example, if you improve primary care for a dual eligible, that's often a Medicaid responsibility, but the savings might be reducing inpatient hospitalization for that individual, and that's a savings to the Medicare program. So that is not a great deal for the state, and also having two program rules to navigate is often very difficult for consumers, for beneficiaries, as well as for providers. So one of the things that the administration did and that the Affordable Care Act also called for is to have an Office of Dual Eligibles, and demonstrations were established allowing states to combine some of the financing, to align the financing and to align the services for dual eligibles. And there's a number of states that have these demonstrations and are at varying stages of implementing those demonstrations. So there's other ways you could think about, 1115 waiver could help with the dual eligible population, but these are demonstrations that are specifically about aligning services and financing for the dual eligible population. And it's under special waiver authority under CMMI.
Okay, well, and Cindy, I wanted to give you an opportunity to review a little bit about what we have planned for the next part of this series, and then I'll conclude the webinar.
Sure. What we thought we would do in the next part of the series is dig in a little deeper to the 1332, unpackage a bit of what I talked about here, talk a little bit about what the guidance says that the administration issued in December, although that guidance is sub-regulatory and might be changed by a new administration. And then walk through a little bit of some examples, a little bit more than we do, just take it a little bit more slowly. And I think instead of just giving you the rules of the game on waivers, to try and talk a little bit about how you might use waivers, what are the different ways in which states have taken waiver authority and used them in 1115, and how they might take that waiver authority offered in 1332 and use that going forward.
Great, okay. We'll be looking forward to it. And Representative Dunnigan, I wanted to give you a chance to make any final comments.
I appreciate the information that Cindy has provided. It's complicated, and sometimes it can be challenging to keep all the waivers separate. I think the 1332s may provide an opportunity, but they also have those guardrails that Cindy talked about, and sometimes those guardrails seem pretty big. So maybe next time Cindy can tell us how to maximize the use would stay within the guardrails.
I would love to do that and look forward to our next time together.
Great, thank you very much, and thanks again to the National Conference of State Legislatures, as well as the Health Resources and Services Administration. Thanks to all of you who joined us today. This webinar has been recorded and will be made available on the NCSL website by next week, and we'll review that as well on the next part of this two-part series. Thank you all. We'll see you next week.